Hi, my name is Kristen James, and I'm going to talk to you about Situs Inversus. What is Situs Inversus totalis? In about 1 in 8,500 people, the organs of the chest and abdomen are arranged in the exact opposite position. The heart is on the right, as is the 2-lobed lung, and the liver, spleen, and 3-lobed lung are on the left. This condition is known as Situs Inversus totalis. Most people are not even aware that they have this condition until something prompts medical attention, as in the case that was accidentally picked up on chest x-ray. A full-time mother expects to have a normal, healthy baby after 9 months of an uncomplicated pregnancy. The baby is delivered without complications, and mom takes her new baby home. A few years pass by, and her baby is now a little boy. On this particular day, the little boy is not feeling well. He is taken to the hospital after being found unconscious. The patient is then intubated, which requires a chest x-ray to determine correct endotracheal tube placement. The tube is found to be correct. Something else is also found on the chest x-ray. All of this little boy's organs are transverse, which is known as situs inversus. It is a condition in which the organs of the chest and abdomen are arranged in a perfect mirror image reversal of normal positioning. Normal human development results in a symmetrical arrangement of the organs within the chest and abdomen. Typically, the heart lies on the left side of the body, the liver and spleen lie on the right, and the lung on the left has 2 lobes, while the lung on the right has 3 lobes. Yet, because this arrangement, called Situs Inversus, is a perfect mirror image, the relationship between the organs is not changed, so functional problems readily occur. Causes and symptoms. Early in the normal development of an embryo, the tube-like structure that becomes the heart forms a loop towards the left, identifying the left-right axis along which the other organs should be positioned. Although the mechanism that causes the heart loop to go left is not fully understood, at least one gene has been identified to have a role in this process. However, it is thought that many factors may be involved in causing situs inversus. Rarely, it can run in families, but most often it is isolated and accidental event occurring in an individual for the first time in the family. Most people with situs inversus have no medical symptoms or complications resulting from the condition. It is estimated that about 25% of people with situs inversus have an underlying condition called primary ciliary dyskinesia, PCD. PCD, also known as Carter-Jenner's syndrome, is characterized as situs inversus, chronic sinus infections, increased mucus secretions from the lungs, and increased susceptibility to respiratory infections. PCD is caused by a defect in the cilia that impairs their normal movement. Diagnosis. Situs inversus should be detected by a thorough physical examination. It is often picked up when a physician using a stethoscope hears otherwise normal heart sounds on the right side of the body instead of the left. To confirm the suspected diagnosis, imaging studies such as MRI, CT, or ultrasound may be ordered, and a referral may be made to a cardiologist for completeness. Imaging studies will also rule out the possibility of random arrangement of the organs, or heterotaxy, which has a much higher risk for serious medical complications. What is the treatment? There is no treatment for situs inversus. It is unlikely case that the heart defect is present. It should be treated accordingly by a cardiologist if need be. Individuals who have situs inversus should be sure to inform all physicians involved in their medical care. In addition to preventing unnecessary confusion, this will reduce the risk of missing a crucial diagnosis that presents with location-specific symptoms such as appendicitis. Prognosis. The prognosis for an individual with situs inversus is good, and in the absence of a heart defect or underlying diagnosis, life expectancy is normal. In my case study, it was on a 4-year-old male who was brought in from an outlying hospital. He was found obtunded at home Over the weekend, there was some winter weather, and he fell and bumped his head on some ice. He did not lose level of consciousness. A few days ago, he became extremely ill, drinking lots of fluids and frequent vomiting occurring. He was found obtunded after laying down for a nap. EMS was called to the home. The patient was taken to Outlying Hospital, at which he was intubated for airway protection at that time. He was then transferred to Pitt. Per the father, he has a history of asthma. He denies any other medical history. The patient is currently mechanically ventilated, and he is not breathing above the set rate. He has heat blankets, so hypothermia is an issue. He is unresponsive when verbally spoken to. His vital signs are blood pressure 107/59, heart rate 92, stat of 100%, temperature 94.6, respiratory rate of 20, which is all vent assisted. His breath sounds are bilaterally clear with minimal secretions. His ventilator mode is APV SINV rate of 20, pressure support of 8, PEEP of 5. His actual PIP is 17. His MAP is 7.8. His CVP is 2 millimeters of mercury, and his blood pressure is continuing to increase. Chest X-ray is suggestive of Situs Inversus and foreign body object in his stomach. Apparently, the little boy swallowed a coin. His initial CT of the head, which was done at Outlying Hospital, was suggestive of cerebral edema. He is unresponsive. His positive corneas pupils dilated. Endoscopy was done in the OR, and a foreign body object was found and removed, which appeared to be a quarter. He had a toxic screen and heavy metal screenings. The toxic screen was negative. Heavy metal screening was still pending. For his assessment, he is mechanically ventilated with a history of asthma, dextrocardia, which means his heart is located on the opposite side of his chest. He has cerebral edema and elevated ICP. He has diabetic insipidus, hyponatremia, hyperglycemia, and hypothermia. Plan of care is to continue mechanical ventilation. He will remain in ICU care. We will wean FiO2 as tolerated. We will consider the risk of exposure to toxic metal ingestion due to swallowing a quarter. Assessment of brain damage needs to be addressed as the patient has elevated ICP and cerebral edema. This patient will be closely monitored. That concludes my case study and my research on this condition. Thank you very much.